All right, chapter 8, we are looking at joints of the skeletal system, or what we would call articulations. So there are a total of 7 sections in chapter 8, and each section has one or two focal points of things that you should be able to learn. And we'll go through those learning outcomes as we visit each section. So in section 8.1, it's our introduction. And in our introduction, we are going to list the functions of joints and explain how joints can be classified according to the type of tissue that binds the bones together and the degree of movement that is possible at the joint. So basically what we do see here is that joints are called, another name for joints or articulations. And basically, joints or articulations are those functional junctions that occur between bones. They are going to bind the parts of the skeletal system together, and they make bone growth possible. They also permit parts of the skeleton to change shape during childbirth. Basically, due to joints, you are enabling the body to move in response to skeletal muscle contraction, and we'll look at skeletal muscle contraction in chapter 9 when we do the muscular system. So there are 3 classifications of joints, and we will consider those 3 types of classification. Basically, when you look at functional classification, you're looking at how those joints move, and then there is structural classification, and that is what those joints are made of structurally. So classification of joints itself, we know that classification of joints can be based on the type of tissue that binds the bones at each junction. That is what would classify bones structurally. Structural classification is used most commonly in the field, and there are 3 basic types of classification of joints structurally. They are fibrous joints. Fibrous joints, you have that dense connective tissue that is going to connect the bones, and it's between bones in close contact. Then you have cartilaginous joints, and that's where you have hyaline or fibrocartilage that is going to connect the bones. And then the most complex are synovial joints, and synovial joints are going to be those complex joints that allow for a lot of free movement. And we'll look at movement terminology later in the chapter. Then you also have classification of joints based on their function. And classification could be, as far as function, can be determined by the degree of movement of the joint at the bony junction. There are 3 types of classification based on function. They are the synarthrotic or synarthroses. Synarthrotic joints are immovable joints. Then you have the amphiarthrotic. Amphiarthrotic joints are slightly movable. And then you have diarthrotic joints, which are freely movable. They have the most movement. So as we go through, you'll revisit some of the structural and functional classification of the joints themselves. So let's look at first the structural classification. There are 3 types of fibrous joints that are synarthrotic. And remember that synarthrotic, these are immovable joints. That would be the syndesmosis, suture, and gomphosis. In a syndesmotic joint or a syndesmosis joint, the core of the fibrous tissue is going to be called a ligament. So what happens there is you get a sheet or a bundle of fibrous tissue connecting the bones, and it's going to be bone between bones. So we see that an example of this we have in here is that connective tissue or interosseous membrane that lies between the tibia and the fibula. This would make it an amphiarthrotic joint. An amphiarthrotic joint means it would be slightly movable. Syndesmosis, the core or fibrous tissue, is that ligament. And another example would be the distal tibiofibular joint. So tibiofibular joint, and you could see that right here. Disto-tibiofibular ligament, interosseous ligament. The next type of fibrous joint would be a suture, and that's when you have short fibrous connective tissue fibers. These joints are considered synarthrotic and are only found in the skull, so they are not movable. Between flat bones, you have sutures. You also have teeth-like projections. You have a thin layer of connective tissue that connects bones of the skull. Here you see those Warmian bones between the suture or sutural bones. And then here you can see the sutures themselves. Gomphosis is the cone-shaped bony process in a socket. And a great example of that would be a tooth in a jawbone. And these are synarthrotic. So these are an example. Gomphosis is an example of an immovable joint. There are two types of cartilaginous joints, synchondrosis and symphysis. In the synchondrosis, you have bands of hydrogen cartilage. So you have a plate of that hyaline cartilage, and what you're going to happen is you're going to have sites of bone growth during the youth. And during the youth, you have bone growth that's going to occur temporarily at that epiphyseal plate. Basically, what will happen is between the manubrium and the first rib, you get costal cartilages. So in synchondrosis, eventually they will ossify and become synarthrotic joints. And what will happen then is you get that joint in the first rib and the manubrium, and you'll have some growth there at that epiphyseal plate. So if you look here, here's that first rib, here's the thoracic vertebra, and there's that costal cartilage, and there's the manubrium of the sternum. The other type is the symphysis, and when we get to the pelvic girdle in our study of the skeletal system, we'll look at that a little bit more. But the symphysis is a pad of fibrocartilage that occurs between bones. We do see that this pad or plate of fibrocartilage will act as a shock absorber. So it is compressible and it will absorb shock. It does have limited movement, so they're amphiarthrotic joints. And we do see this in two areas of the body. You have that fibrocartilage between connecting the pelvic girdles there. That would be your pubic symphysis or symphysis pubic. And you also have the intervertebral discs that occur between the vertebrae. And again, we looked at that a little bit when we were talking about the vertebral column in lab, and those would act as a pad or a shock absorber between the vertebrae. Most joints in the body, however, are those synovial joints. And synovial joints in general, they are all diarthritic. They do allow free movement. They consist of articular cartilage, a joint capsule, and a synovial membrane. And that synovial membrane is going to be used to secrete synovial fluid. So the basic structure, very limited, general basic structure of a synovial joint is that articular cartilage, joint capsule, synovial membrane. So if we look at it a little bit in greater detail, here you see the general structure of a synovial joint, and there are specific parts of the synovial joint. The basic parts are the articular cartilage, synovial membrane, and the joint capsule. So if we look at that, what does the articular cartilage do? The articular cartilage is going to be that hyaline cartilage that covers the surface of each bone. And then you have the joint capsule. And the joint capsule is going to be that double layered capsule that is surrounding the joint cavity. And that double layer capsule around the joint cavity externally contains a tough, flexible, fibrous capsule that is continuous with periosteum of bone. So you have that periosteum of bone that's going to form externally. And then you also would have in there a synovial membrane. And the synovial membrane is going to be the loose connective tissue lining of the fibrous capsule. And that is also covers all the internal joint surfaces excluding that hyaline cartilage that you are going to see within the joint cavity itself. And then what will happen is that synovial membrane will secrete synovial fluid into the synovial cavity. So the synovial cavity is the potential space between the two bones, and it does get filled with synovial fluid, as you can see in the diagram there. And basically, what purpose does the synovial fluid serve? The synovial fluid is viscous, and in being viscous, it's going to serve as a lubricant fluid within the cavity. And when it serves as a viscous lubricant fluid, it's going to do a couple things. One, it's going to reduce the friction between the two cartilages of the two bones. It's also going to be a lubrication for the bones, and it's going to serve as a nourishment for the cartilage within that joint cavity. It also contains phagocytes, and phagocytes will help collect dead cells, so via endocytosis. In addition to the parts of the joint, you do have some reinforcing ligaments in there. Remember, synovial joints do allow a lot of free movement and are very complex, so you do have a lot of extra ligaments that help strengthen that joint. A ligament in general, ligaments join a bone to another bone across a synovial joint. So it's going to be the tissue that connects bone. Usually the thickened portions are the fibrous capsules, which are intrinsic or capsular. Other joint features that you have there would be fatty pads. You could find fatty pads in the hip and in the knee joint. You do also get things called the menisci or the articular discs. Menisci or articular disc, they are going to be used to separate the cavity into two compartments. We do see that the menisci or the articular discs, where you get that separation of compartments, is common in the knee joint, the joint of the jaw, and the sternoclavicular joint. The last thing that you have as a special feature of a joint are things called bursae. And the bursa, a bursa is a flattened or fibrous sac within the synovial membrane and fluid that is going to act as sort of like ball bearings in a tire. And basically what happens is that fluid acting as like a ball bearing is going to prevent friction on adjacent structures during joint activity. So getting back to, sorry, I was interrupted. Getting back to the structure, the bursa do act as the friction reducer to adjacent joints. So basically what will happen there is it will cushion the movement of one body part over another. It's located between the skin and the bone, where skin rubs over bone, and between muscle, tendons, ligaments of bones. So there are several types of synovial joints. The 6 types of synovial joints we will examine. The first type of synovial joint that we will look at is the ball and socket joint. Ball and socket joints are most freely movable joints and permit all angular movement. And basically in a ball and socket joint, the head of one bone fits into the socket of another. An example would be the hip and the shoulder joint. The next type is a condyloid joint or ellipsoidal joint. This is going to permit all angular motions except rotation. We do see examples of condyloid joints in the wrist and knuckles. Then you have gliding joints. Gliding joints are cartilaginous joints. An example of a gliding joint would be between the facets of adjacent vertebrae or the intervertebral discs. The next type, or the 4th type of synovial joint, is a hinge joint. Hinge joints will permit flexion and extension only. Now we'll look at joint movement types in a little bit. but hinge joints permit flexion. Flexion is decreasing the angle between the two bones, and extension is going to increase the angle between two bones. What we do see here, an example of a hinge joint would be the elbow and the knee joint. Then you have those joints that are pivot joints. Pivot joints permit rotation. An example would be between the atlas and the dens of the axis. So it's that first intervertebral joint, the anteroaxial joint. The anteroaxial joint is going to permit the rotation, and you can see the rotation of the head there. And lastly, you have the sixth type of synovial joint called a saddle joint. And saddle joints allow for opposition. And basically, what you see there is a joint between carpal and the first metacarpal of the thumb. So joint movements, section 8.5 of your textbook. Movement at a joint occurs when a muscle contracts and its fibers are going to pull its movable end, the end where you have the muscle insertion, towards its fixed end, which would be the origin. So the origin is the part of the muscle attached to the immovable bone, and the insertion is part of the muscle attached to the movable bone. When a muscle contracts across a joint, its insertion is pulled towards its origin. So there are terms used to describe the movements at joints that occur in different directions and in different planes. And we will look at some of those terminology. So you have abduction and adduction. Abduction is moving a limb away from the midline. An example would be raising the arm or thigh laterally. Adduction is moving a limb toward the midline. You also have dorsiflexion and plantar flexion. Dorsiflexion is bringing the toes toward the shin. Plantar flexion is pointing one's toes or flexion toward the sole. Flexion, extension, and hyperextension. Hyperextension, flexion is decreasing the angle between two bones. Extension is increasing the angle between two bones. And hyperextension is increasing the angle greater than at the anatomical position. So an example of that, when you have your body in the anatomical position, if you were to hyperextend your head, you would bend the head back beyond the position it would be in the anatomical position. And then you have a thing called lateral flexion. There is also rotation. Rotation is a turning movement of a bone along its axis. Circumduction is moving a limb in a circular, cone-shaped manner. Supination and pronation. Supination is thumbs up. Pronation is thumbs down. Eversion and inversion. Eversion is sole outward. Inversion is sole inward. Protraction and retraction. Protraction is moving a part of the body forward. So it would be like moving your chin forward. And then retraction is when you're moving that part backwards. So it would be pulling the head back. You do also have, really quick, protraction, retraction, and then you have in the diagram there you can see elevation and depression. I forgot those two. And elevation is raising a part, such as shrugging the shoulders, and depression is lowering a part, such as depressing the mandible. So those are types of movements, types of joint movements. So let's look at, in section 8.6, some very specific examples of synovial joints. Specific examples that we will look at are the shoulder joint, the elbow joint, the hip joint, and the knee joint, which are large and freely movable joints. Basically, in the shoulder joint consists of two joints. The shoulder joint exists of two joints, and what we see here is you have a ball and socket joint, and the head of the humerus or the glenoid cavity of the scapula are going to articulate. And basically, it's a loose joint capsule. You do have some bursa. You have a ligament to prevent displacement, and you have a very wide range of movement, such movement to allow for circumduction. So taking a closer look at the shoulder joint, it is a ball and socket joint that is a glenohumeral joint. So the ball and socket joint is the glenohumeral joint. So you have the gleno cavity and the humerus that are going to interact there. It joins the glenoid cavity and the head of the humerus. Its a syndesmosis is called the acromioclavicular joint. So the syndesmotic joint is the acromioclavicular joint, where you're going to have the acromial end of the clavicle and the acromion process of the scapula interact. So here is the joint here. So the acromial process and the clavicle are going to interact right here. Here is that glenoid cavity, and then you have the humerus that is going to interact, the head of the humerus that's going to interact with that glenoid cavity there. The ball and socket of the shoulder joint is surrounded by many reinforcing ligaments and tendons, collectively called the rotator cuff. And you probably heard of, I think common in pitchers, you could get a tear in the rotator cuff. If you read on page 280 in your textbook, it talks about rotator cuff injury. So take a look at that and read over it. There are many bursae that also lubricate the shoulder, and movement can occur in any angular plane. As we said before, you do have that circumduction that is permitted for movement. Also in your book, I think there's a discussion somewhere talking about shoulder, a dislocated shoulder. So we'll look at that a little bit in class. The next type of joint there would be the elbow joint. It's two joints that are working together to create the elbow joint. The hinge itself is between the trochlea of the humerus and the trochlear notch of the ulna. You do get a gliding joint in there, and that gliding joint is going to be between the capitulum of the humerus and the head of the radius. And we'll look at some of those parts when we break down the appendicular skeleton. Basically, it is a very stable joint with many reinforcing ligaments, and it allows for both flexion and extension of the elbow there. You may have heard of tennis elbow. We'll talk a little bit about tennis elbow a little bit later. So here you can see how that joint would look. Basically, you have your joint capsule. You do have that nice synovial membrane that's going to secrete the synovial fluid in the joint cavity. You also have the articular cartilages. You have the coronoid process right here. You have an angular ligament, the radius and the ulna, and your elbow there, that would be the olecranon process of the ulna, and here you have the trochlea. If you look again, you have the medial condyle, epicondyle, you have a lateral epicondyle. There's your angular ligament, the radius and ulna, and you can see how that all interacts there to create the elbow joint with the olecranon process. So we didn't get much into the anatomy yet of the appendicular skeleton, but we will get there, and this will make a little bit more sense once we do. The next type of joint would be the hip joint, which is a coxal joint. Basically, in the hip joint, you have another ball and socket joint. In the ball and socket joint, here, you're going to have the fovea capitis on the femur head that's going to play a role. It contains many large reinforcing ligaments, and it allows for the same movement as the shoulder, but with less range due to the bony limitations. So in this ball and socket joint, you're going to have the head of the femur and the acetabulum of the hip bone that are going to interact. It's a very heavy joint capsule, many reinforcing ligaments, as you can see in the diagram there. So here's your hip bone. You do have the acetabulum in here, to which the head of the femur, the head of the femur is going to fit into. Here you can see some of those reinforcing ligaments that play a role in the hip joints. So you have the iliofemoral ligament, the greater trochanter of the femur. You have the pubofemoral ligament. There's the pubis, the ischium, the iliofemoral ligament, and the ischiofemoral ligament. Okay, the largest and most complex joint is the knee joint. It is the largest and most complex joint for many reasons. It's going to function as a hinge, even though the three joints are working together. You have the medial condyles of the femur and tibia that make one condyloid joint. You have the lateral condyles of the femur and tibia that make another condyloid joint. You have the patellar surface of the femur and the patella that are going to make up a gliding joint, and that's going to permit flexion and extension of that joint and also allow for some rotation of the knee joint. So again, most complex, you have three bones that are interacting. You have the medial and lateral condyles of the distal end of the femur and the medial and lateral condyles of the proximal end of the tibia, and the femur is also going to articulate anteriorly with the patella. So you can see all three bones and how they would interact right here on the diagram. And then it's going to be strengthened by many ligaments and tendons. The menisci are going to separate the femur and the tibia, and then you're also going to have bursa. So if you look in there, you have the extracapsular ligament. And the extracapsular ligament, I'm going to flip to this page here. The extracapsular ligaments are found on the outside joint capsule. You also have the patellar ligament, so outside the joint capsule patellar ligament. You have the tibial collateral ligament, or the medial collateral ligament. And the medial collateral ligament is abbreviated the MCL. And then you have the fibular lateral collateral ligament, or the fibular collateral ligament, or the lateral collateral ligament is the LCL. So let's look at, once again, let me just quick go over those extracapsular ligaments. The MCL, the medial collateral ligament, is also known as the patellar ligament, or no, wait, the tibial ligament. And then you have the LCL, which stands for lateral collateral ligament, which is also known as the fibular collateral ligament. In addition to those two, the MCL and the LCL, you have the joint capsule patellar ligament. You also have an intracapsular ligaments found inside the joint capsule. And the one that is intracapsular would be your anterior cruciate ligament. And this one you've most likely heard of. The anterior cruciate ligament is known as the ACL. So you have the MCL, LCL, and the ACL. Then you have the menisci. And the menisci, you have medial meniscus and a lateral meniscus. And basically what's going to happen here is the medial and lateral meniscus are going to be in C-shaped fibrocartilage pads, and they're going to reshape the tibial condyles for a better fit and absorb shock. And you could read about torn and displaced meniscus of the knee in the book. And then you have many bursa that are also going to play a role in there. And if I come back to here, you could see the bursa, and they're going to play a role in helping to reduce the friction there. All right, so lifespan changes, bringing us to the end here. Basically, this is the entire chapter. So lifespan changes, joint stiffness is an early sign of aging. Basically, what happens is fontanelles of the skull do harden in the first 2 years. The epiphyseal plates harden from ages 14 to 20. Fibrocartilage loses water, and it's going to decrease flexibility of the intervertebral joints and knees. Collagen changes will cause stiffening beginning at about age 30. And then exercise is a way to help decrease the onset of joint stiffening. So you do see that fibrous joints are the first to change and can strengthen over a lifetime. You do get the changes in the symphysis joints of the vertebral column, diminished flexibility and decreased height. Synovial joints lose their elasticity, so their ability to stretch and then come back to normal form. Disuse hampers the blood supply, but activity and exercise can keep those joints functioning a little bit longer. So I hope you enjoyed chapter 8. That is the entire chapter. We will do a little discussion on it in class as we continue to break down the skeletal system, and we'll have our chat test on the joints sometime within the next week, and we'll also have our lab practical to follow. Thank you and have a nice day.